Alrighty. Hello, everyone. How are we all doing today? Can everyone hear me on there? Just give us a little thumbs up. Thanks, Kerry. Nice to see you. Wonderful. Thanks, Summer. Fabulous. All right, so we'll get straight into it. So we've got our birds and BBVs, and can everyone see that there as well? We'll just get into that. We're sharing a window. Lovely. So fabulous. Thank you. So before we get started, I would just like to acknowledge that we are meeting here today on Whadjuk Noongar Butcher, and I just like to pay my respects to elders past and present and emerging, and just extend that respect to any Aboriginal people in the room and online today. My name's Liberty. I'm acting as the project coordinator over here at the Aboriginal Health Council of WA. And today we have got public health physician, Dr. Donna Mack, who's going to give us a nice overview on the antimicrobial resistance in gonorrhea. So I'll stop sharing my slides there, Donna, and take it away. Thank you so much.
Now, can people see my slides or not?
No, Donna.
No, that's okay. That's all good. I think we'll go to that.
Fabulous. And I'll just say as well before we get started, if you've got any questions, we can just pop them in the chat or just raise your hand. We'll have a lot of time for some questions at the end.
And I just want to make sure when I move the slides back and forth, does that change what you see?
Yeah, that was changing, Donna. I could see that for sure.
Yep. Okay. Oh, good. Okay, so we will start. Thanks very much, everyone, for attending today. And I'd also like to acknowledge that I'm on Whadjuk Noongar Butcher and pay respects to elders past, present and emerging, and also acknowledge the lands on which everyone is joining us from today. So this presentation I actually gave just 2 days ago at the Communicable Disease Control and Communicable Disease and Immunisation Conference in Adelaide. And it's about gonorrhea antimicrobial resistance and what I see as some of the gaps that we have in our surveillance system for gonorrhea AMR in WA and indeed in the rest of Australia. So since the COVID-induced restrictions in overseas travel, which among other things, had the effect of reducing our gonorrhea notification numbers and rates. Gonorrhea has truly come back again. You know, it's on the rise, and with increasing overseas travel, we're seeing increased numbers and rates, not just in Western Australia, but around the whole of Australia. Western Australia is really a very unique place for gonorrhea. It's the only place in the world where we have sufficient numbers of penicillin-sensitive gonorrhea, to the extent that we currently have 2 regions in Western Australia where it's still okay to use azithromycin, amoxicillin and probenecid, which is an oral treatment for gonorrhea. There's actually no other place in the world where that happens because of the extent of penicillin resistance. And in the rest of Western Australia and Australia, the standard treatment for gonorrhea is ceftriaxone and azithromycin. So in Western Australia, we have 2 methods for AMR resistance. So culture is the traditional method, that has been going on for decades now. Unfortunately, culture only covers about 15% or less of notified cases, and the vast majority of those are from the metropolitan area, because many doctors now will not take a swab for culture, and if the patient doesn't have symptoms or pus, there's actually no point in taking a swab for culture. And in the rural and remote areas where it takes a long time for the swab to get to a laboratory, there also is no point in taking a swab for culture because the gonorrhea is very likely to have died during the transport. Culture for gonorrhea tests for resistance to penicillin and ceftriaxone, which are the antibiotics that we use for treating gonorrhea in Western Australia, and also quite a few other antibiotics which we don't use routinely for treating gonorrhea, but it's useful to, from a surveillance point of view, to know how gonorrhea is behaving with regard to resistance in a wider range of antibiotics. We're very lucky in Western Australia that PathWest has developed its in-house molecular method for detecting plasmid-mediated penicillinase. And that has been operational since November 2011. And they also developed an in-house test for ciprofloxacin resistance, which has been implemented since September 2020. So that covers all the gonorrhea that goes to PathWest QE2, which is all the non-metropolitan areas in Western Australia. From the middle of 2023, PPNG testing of gonorrhea positive PCR samples from 2 private laboratories that service the Goldfields, the Kimberley and the Pilbara was started. And so that has improved our coverage of AMR surveillance in the rural and remote areas. And from late 2024, PBNG testing of gonorrhea positive samples from the Aboriginal Community Controlled Health Services, where there are point of care testing machines, that's also been happening. And so we are not missing out on penicillinase production surveillance in those point of care testing sites. However, what we do not have in Western Australia, and no one in Australia has this, is routine testing of gonorrhea samples using molecular methods or non-culture methods for ceftriaxone resistance. So the next slide shows the number and proportion of gonorrhea notifications in metropolitan Perth on the left-hand side and in non-metropolitan areas on the right-hand side that are cultured. And you can see that over time, both the number and the proportion of gonorrhea notifications in metro and non-metro areas in Western Australia has been reducing. And it's particularly low in the non-metropolitan areas. So we're not really getting a very complete picture of what's happening with ceftriaxone resistance because it's just such a small sample of gonorrhea notifications that undergo culture where we could possibly find out whether it's ceftriaxone resistance. And the reason for that low level of culture of gonorrhea samples is because the vast majority of gonorrhea notifications come from general practitioners, whether they be in Aboriginal medical services or private GPs in the metropolitan area, and they generally would not be taking swabs for culture. So this next graph shows the number of gonorrhea notifications by penicillin antimicrobial resistance in Western Australia. And we can see here that when we started getting data from private labs, so as designated by this line here, that the number for which we had no data reduced, and and conversely, the number that we do have data for. So the blue line is the ones that are not penicillin resistance, and the orange line is the number that are penicillin resistant, that's also increased. And you might say, well, this trend here isn't good. And I agree it's not good, but at least we're knowing what it is, because before it was just sort of like hovering down here because we didn't know, because the number of unknowns was much higher. And so this is showing the proportion of gonorrhea notifications by penicillin antimicrobial resistance. And we can again see there the effect that getting data from the private labs has had, in that, we can see a big jump in this blue bar and a reduction in the proportion of unknowns. And there is a gradually increasing trend in the orange bar, which is the proportion with penicillin antimicrobial resistance. So that's for the whole of WA. And if we look at it by region, you can see that essentially it's the Kimberley that is the last bastion of penicillin-sensitive gonorrhea. Late last year, the Pilbara stopped using penicillin in ZAP packs to treat locally acquired gonorrhea, because their proportion of resistance had gone up to 8.1%. And those of you who are looking at this graph might be wondering why we didn't call the same thing out for the goldfields. And it was because when we made that decision for the Pilbara, we didn't actually have all the data for the goldfields for 2024. So in WA, we don't see a lot of ceftriaxone resistance. When we do, we really follow it up quite vigorously, with proof of cure tests to make sure that the person isn't transmitting it. However, in other parts of the world, there is a lot of ceftriaxone resistant gonorrhea, and especially in parts of the world, like around here, where we have, large populations that fly in and fly out because they work in the remote areas in the north of Western Australia. And there's a particular clone of gonorrhea called the FC428 clone that is particularly associated with ceftriaxone resistance. There are also other genotypes of gonorrhea that are associated with ceftriaxone resistance, but this is one of the major ones. And that particular clone is found in many of the countries where there's a lot of travel between that country and Australia. And unfortunately, the prevalence of that clone in those countries seems to be increasing. So there have been, calls in the literature for a better commercial test to identify ceftriaxone resistant gonorrhea, because at the moment, really the only way of identifying it is to be doing whole genome sequencing, or something that is quite close to whole genome sequencing. And it's not a technique that is able to be done cheaply and routinely across all labs in Australia. So if we do have ceftriaxone resistant gonorrhea in Western Australia, what are our options? Well, there have been papers that have called for increasing the ceftriaxone dose. So currently the dose we use is 500 milligrams intramuscular. There's been papers that have said you can use up to 3.5 grams intramuscular, to get the blood levels higher than what the gonorrhea can live in. So, that is an option. Other people have said, well, perhaps we should be making more use of Cipro. If we have real-time testing for Cipro resistance, we could use Cipro if the gonorrhea is sensitive to that. However, the experience internationally has shown that once you start using Cipro for gonorrhea sensitive for gonorrhea that are sensitive to Cipro, it doesn't take long. Within 1 or 2 years, they all develop Cipro resistance. So it might be a way of sort of tiding you over, but it will not really be a permanent solution. There's not a lot of new antibiotics out there. This one, which I don't know how to say its name, but has been reported in the literature as a potential new antibiotic that could be used for gonorrhea, but it's still in clinical trial stages yet, so it's not actually anywhere near available. So I think what we actually need is better surveillance in Western Australia and Australia-wide for ceftriaxone antimicrobial resistance. And that we actually need governments to invest in it, in the way that the federal government has actually invested into the development of Australia's first syphilis self-test, which includes not only testing for antibodies to treponema, but it also includes the equivalent of an RPR test. So I think if our Commonwealth government is willing to invest in that to help fight the syphilis outbreak, which has been going on for some time now, it probably should think about investing into better surveillance for ceftriaxone resistant gonorrhea, because at the moment with our surveillance mechanisms, it is quite possible that a ceftriaxone resistant genotype could be imported, and it could spread quite widely before we even know that it's here. And I think probably the only thing that's saving us at the moment is that the current ceftriaxone resistant clones, they don't spread very well. They're not really good at transmitting between people because the genes that encode for their resistance somehow seem to reduce their fitness to reproduce. But there may come along a gonorrhea that is both ceftriaxone resistant and has fitness to reproduce. And if that happens, then we kind of might be a bit up the spout with, bit up the creek without a paddle and not sure of where to go. So I'll finish up there and very happy to take any comments or questions. And yeah, I want to learn from you now.
Awesome. Thank you so much, Donna. I'll get us started. I suppose just a question on the back of the just those goldfields, the numbers there. When would you expect that they would transfer over to the LACs?
So I was talking with the physician and the registrar who are responsible for the goldfields, and they are going to do some analysis of it themselves, and we'll work with them to decide when that will happen.
Wonderful. Lovely. Yoli?
Thanks, Donna. What an interesting and difficult situation we see ourselves in. You mentioned that you presented this 2 days ago at the national conference. I'd be really interested to know if any interesting comments or questions arose in that sort of national level discussion. Anything that you could share?
No, I mean, people were interested in it, but in the same way as you, they didn't really have any solutions.
Yeah, I definitely don't have solutions, that's true.
Yeah, they did not disagree with the need for us to be able to do something better, but they weren't really quite sure of, where to go or where we'd get the money to do what we need, what needs to happen.
I guess I'm obviously in wax, and that issue of low culture detection across wax sites, and the two main groups in your slide showing primary care and AMSs as the environments where, sorry about that, where culture is actually being requested. But we've got to up our game, certainly in that respect. How can we improve our surveillance if we don't? It is a message that I'm putting across at all of my GP sessions whenever I'm on this topic. Any other work that could be done, RACGP, WAFA, just to again push that message about the need for culture?
I think the problem with relying on culture. And I'm not saying we shouldn't do it. I think we should do it whenever we can. But I think even if you did it whenever you could, when you've got a patient with pus, that is a small proportion of patients with gonorrhea who actually have pus that you can take a swab of. And if someone has got pus and they're, in a remote Aboriginal community, and that swab is not going to get to the lab for several days, I actually don't think it's worthwhile bothering the patient with it. Because all it does is it increases the cost, but for absolutely no gain. And I think certainly in regional centres where the swab could be taken and arrive in a lab where it can be plated out in a few hours, that's something that we should be pushing. But we're really, what are we talking about, Yoli? We're talking about probably Kununurra, Broome, Headland, Karratha, Geraldton, Kalgoorlie, and the other parts. They don't see a lot of gonorrhea. Like we could talk to people in Bunbury and Busselton until the cows come home, but I don't think they're ever going to collect terribly much.
Yes, difficult.
Yeah, so I think it's difficult, and I think when we ask people to do things, we should ask them to do things that actually they can do, because if they don't do them, like, I don't want them feeling bad. We need to keep them as friends.
Yes. Path West probably doesn't have any sort of regional solutions that they are able to work on that I would imagine, but presumably Michael's had the issue presented to him, and like you say, it's a cost issue. That's really what it comes down to. Yeah,
and it's not just Path West, it's actually the transport. We can't be chartering a plane to fly in a sample with pus on it.
The new antibiotic that we can't pronounce the name of.
Yeah.
Do you know much about it? Where is it being used?
I could probably send. It's not being used, is my understanding. I found a paper on it, and it was like a clinical trial paper. But I'm quite happy to send PDF versions of those papers that I've referred to in the slides to Liberty, and then she can send them around to anyone who's interested in reading them. But, it was a small trial, Yoli. It was like, I don't know, less than 50 people in it. It was
very small.
And I think it's a long way off.
Thanks.
Still quite exciting though, Donna, to know that maybe there's a bit of a change with that antibiotic out there, so that's cool. Anyone else out there? I think that was really nice clearing that up as well, just with the regional sites versus the remote sites, just with those days, the amount of time that you could have to get them to the lab. So I think that's really nice versus that Broome versus, Balgo or something. So that's cool. Thank you for clearing that up. Anyone else? While we're there, I'm just going to share just a little feedback form as well, and I'll send this out. So there is just a little QR code. Hopefully everyone can see that. Does that come up? Yep, cool. Wonderful. Any other questions from anyone out there? No, all looking pretty good. Lovely. All right, well, I guess we'll wrap that up, Donna, if you're okay with that. It was a lovely, beautiful overview of where we're sort of sitting. If anyone does have anything burning later, just give us an email and I can pass those on to Donna and saying we'll get those slides and send those out as well. But otherwise, I guess, thank you so much, and lovely to see you again. Lovely to see everyone online. And I'll release the next bite in the next few weeks or so, which will be exciting.
Thanks very much, Liberty. Thanks very much, everyone, for coming. Bye.
Thank you. See ya.
Thank you.
Thanks, heaps.